Good morning, everybody. Is everybody awake? Yeah, okay, good. That's a good sign. Anyway, welcome again. We're happy to see you here today, especially that it's a closing day, so we know that maybe we will not get the average crowd that other sessions had because people are just trying to meet, trying to last deals, last knowledge, and last type of arrangements, but I'm happy that you're here. My name is Rudolph Chandler. I'm with the Track 20 project. And the purpose of this session is really to present what we have in terms of government expenditures on family planning, both at the domestic level by country, as well as some of the work we do by international, that is like global, that is like summing it up. So that's kind of like the way we're going to be doing it. And for those of you who are health account specialists, I'm not sure I recognize people here. This is just what we're going to be presenting is the equivalent of the current health expenditures, total health expenditures slash for family planning that the WHO generally does. Of course, you know, it's a totally different approach from what it's being done in the health accounts, but that's kind of like the way we're gonna present it to you, okay? The collaborators, the institutions that are present are, I'm gonna name them by people and name, but you know, some of them are not here. First, I want to introduce my colleague, Julius Correa from the University of Nairobi, who pioneered for us a tool to do what we call the family planning spending assessment, which we are using. We started with only domestic expenditures. For some countries, we do it also with international donors and NGOs, but he's gonna be presenting the family planning spending assessment that's done for Kenya for government, okay? The second presentation, who I'll mention why, is from Adam Wexler from the Kaiser Family Foundation, and presenting the way that KFF, that's the acronym, estimate bilateral donor disbursement for family planning. Then there's also Dr. Angela Mika from the Institute of Health Metrics at the University of Washington, who also does some donor expenditures, very similarly, you'll see, to what the Kaiser Family Foundation does, but their contribution to the whole process is on the philanthropies and corporations, the way they're pulling that part of it. And then finally, and I like to say not least but not last, my colleague Michelle Weinberger, who is also with Track 20 and Avenir Health, and she's presenting the estimates of out-of-pocket expenditures from her work with the Reproductive Health Supply Coalition. Now, you know, here we are, I introduced 4 people, it's only 3 of us, well, I introduced 5 people, but it's only 3 of us. Dr. Micah could not make it the last minute, neither could Adam Wexler, so the University of Washington, she recorded a video of her presentation, so that's what we're gonna show you. And I will try to do my best to be Adam Wexler in presenting his data, and he's so good at it. It's so impressive the way he does his presentations that I kind of like, ooh, I hope I don't fall short, so don't be mean at me if I'm not as good as he is. The one regular collaborator to the whole process that's not present, for which we don't have a presentation, is also the WHO, the health account groups, because they do contribute, and at the end of the session, I will show you how they contribute to the whole process of giving us some data to come up with the global expenditures also, well, country estimates that we put in global expenditures. So with that said, I will also wrap up at the end, kind of like how we all pull it together. And with that said, I will pass the baton to my colleague, Dr. Julius. Uh-huh. Okay.
Number 2, I have a comment that today there is a constraint in the buses.
Yes.
So one bus is rotating for more than 1 hour for all of it. So you may find that the people is coming.
Okay. All right. Well, thank you. So yeah. So and the other thing also is that, you know, if we could keep all the questions together at the end. But thank you for the comment. No, thank you for the comment, because yes, we know that there's an issue, and my colleague Michelle, she has another presentation right after this, so we need to keep it according to the time. So Julius, why don't you go ahead and start explaining what you do? And the one thing I want to say about what Julius is going to presenting, we're just presenting the Kenya case here, but that's a rule, that's a methodology we apply for a number of countries, and we'll come to that later. Go ahead, Julius.
Okay, so morning. So I'll go straight to the presentation, and this is what we're calling family planning spending assessment. So in terms of our presentation, we have put it in terms of 4 sections. The methodology that we use, the dimensions that we also generate in terms of the results, the uses of the results, and conclusions. So the FPSA as a methodology is a comprehensive approach that is used to determine the flow of resources for family planning. Now, so when we talk about the flow of resources, a lot of that is really financial resources, but sometimes we also capture non-financial resources. So this tool really tracks expenditure. We are not using this tool to measure disbursements or commitments. We only measure expenditure. Now, this tool was adapted from the National Health Accounts, and specifically, we also made use of what we call the National AIDS Spending Assessment, which is a methodology that is used to track expenditure for HIV and AIDS intervention. So, borrowing from those 2 methodologies which are already being used, FPSA then applies a standard accounting methods to reconstruct transactions in a given country through the approach which we say following the money from the funding sources to the agents to the providers. So we say that we reconstruct all the transaction. Now, a transaction is a flow of resource from one entity to another entity. So in the transaction, we have 2 components. It is in-out, or a debit and credit. So that is the approach that we use to trace out the flow of funds. And in tracing this flow of funds, we apply what we call top-down approach, if it is possible to get information from the sources. And then we move down to the agents, and sometimes we start from the providers upwards. So we apply 2 methods, the top-down and bottom-up. So this is the way we triangulate data that we collect from the different sources. So we have 3 dimensions here, and all these 3 dimensions capture expenditure. In terms of financing, we measure or track expenditure in terms of financing sources and financing agents. Now, the agents are entities that pool resources, and then they give to service providers to provide services. Now, under provision, we have service providers, could be health facilities, could be pharmacies, and then within service provision, we also capture expenditure by the things which are used to generate those services, and we call those inputs. Then for under consumption, we have also 2 subcategories. We have beneficiary population. We can measure expenditure by beneficiary population, and we also measure that expenditure by the type of services which are provided. Now, currently, in FPSA, we do not capture expenditure by beneficiary population. However, we have also changed slightly our classifications so that under the provision, we also capture, we combine the inputs and services, and we call them FPSC, that is family planning spending categories. So we want to emphasize that in FPSA, we track expenditures for FP services, not budgets and not commitments. Now, this is where we have applied FPSA in Kenya. We have done it for about 6 years. And when we are doing this FPSA, we collect data by conducting a survey to collect primary data, or we use secondary sources. A lot of this, we use secondary data. Now, in terms of the FP commodities for Kenya, all that information of the data can be found, or we collect that data from the Kenya Medical Supplies Authority. So this authority has information on expenditure by the type of commodity, by the source of funding, by county. In Kenya, we have 47 counties, by facility level, different levels of facilities, and even by ownership of that facility. Now, in addition to the commodity, expenditure on commodities by different sources, we also collect expenditure from what we call IFMIS, which is Integrated Financial Management Information System at the Ministry of Finance. We call it the National Treasury, which has expenditures by the counties. Then in addition, of course, we also get data from the Ministry of Health because we follow the money from, we use different sources to triangulate the data. Now, this is just the kind of information that we can get from KEMSA. We have the name of the county, the type of facility, the product that is distributed to the different facilities, source of funding, the quantity issued, the unit cost or the unit price, and we have more information, a lot of information. So this is just a screenshot or part of what is contained from KEMSA source. Then from IFMIS, we can have data on salaries and other operating costs. So note that in our case, expenditure on salaries, we don't have it very specific to FP. In facilities, healthcare workers provide services generally. So we capture the expenditure on salaries, and then we try to allocate to FP. And in terms of the allocation, we try to use data on utilization from DHIS. So this is just for one year. And it's very comprehensive. It captures the inpatient, outpatients, and even the different services. The details are there. So we use this data to be able then to calculate the proportion of expenditure, the one that is shared across the different services to family planning. Now, this is just an example of the way we do it. And I think for the countries now, we have about 31 countries implementing FPSA. We have already generated for each country what we call equivalency ratio, which has a key, allocation key of shared expenditure to FP. So you see for Kenya, it's about 4.2%, around 4%. It goes to FP, but note that when we are doing that ratio, it's a bit unweighted because services will take different outpatient services, and even inpatient services may take different times in terms of provision. So we have like the MCH, those are visits, FP visits, general OBD, which are excluding those above, inpatient days, and then we convert inpatient days into what we call inpatient equivalent, and then we sum to the total outpatient visits to get what we call inpatient total visits. And then we get a ratio of FP visits in the total to give us, it's a crude measure. It's not really because we don't weight it, but it's a measure of what is the contribution of the total expenditure, which is shared for FP. Now, so for the periods that we have considered, we have two levels of government in Kenya. the national level and the county level. So these are the expenditures which we tracked for the years that we have considered. The first FPSA, which was the very first one, we covered financial year 2014-15 and 15-16. In Kenya, financial year starts in July, ends the following year in June. So these are the expenditures in million of US dollars. And we see that from 2014 to 2015, there was a decline in total government expenditure up to 2016-17, when government now started to prioritize FP commodities. For this year, government was not putting in money for commodities, so the amount, the expenditures now started to increase, especially from the national government. You see there is increase in 2018-19 and 19-20, and part of that is attributed to government expenditure on FP commodities. Now, so this is just a summary of the same information based on the tool that we use. So we have an Excel-based tool that we can populate, and then we generate results. And this is for 2019-20. So we have expenditure by the second level of dimension. Remember, we say in financing, we have the sources, which I've already captured up there, and then we have what we call the financing agents. Now, in terms of the government money, that money goes through the Ministry of Health and county department, not count, but county department of health, and as agents. Then we have expenditure by the different service providers, and know that when we talk about service providers, we are not only talking about health facilities, because we have like program management, which is undertaken by specific department in the Ministry of Health or the county department of health. So we have, again, disaggregation of that total expenditure in terms of different providers for the national level and also for the county level. Then lastly, and this is very, very important, we disaggregate that total expenditure in terms of the different services. So it's called family planning services categories. We used to have them separate. Remember, for those who have been involved in the national health accounts, the national aid spending assessment, we usually have expenditure by services and then expenditure by factors. But we found for us it's very useful for policymakers to have it this way, where we have combined both inputs and services. So, for example, we have expenditure on staff, that is an input, and then, so we have that total expenditure on those who are providing services directly. And that's why for national government, we don't have anything. In Kenya, service provision is at the county level. And then we have other categories, the contraceptives, medicines, and other consumables is basically contraceptives. And so we have the different costs across different types. Then we have what we call above side level expenditures, and some are also site level expenditures in terms of logistics, demand creation, IC, policy development, and advocacy. Of course, we didn't have expenditures for some of these categories. So in terms of uses of these results, the results have been used to report for indicator 12 under FP 2030 for Kenya for a number of years. So we have used these results to report government contribution. Now, the results also have been used to inform development of CIP for Kenya, which was completed early this year. And generally, the results can also be used to advocate for increased funding for family planning, and also can be used to monitor progress in terms of implementation of CIP. To conclude, based on our results, really, the expenditure, a lot of that expenditure which we have seen is mainly on healthcare workers. And that is mainly from the county government. And all the contraceptives currently are funded by national government and donors. Of course, we have not presented the results for the donors. And of course, we have seen in recent years increasing government expenditure. Now, so this activity is one of the things which are done by Track 20 under data analysis. So FPSA is one of them. We have FP 2020 report, FP 2020 co-indicators, and FPSA is one of those activities which are undertaken. Thank you, Rudolph.
Thank you, Julius. So for time safety in time, since my colleague has another presentation, let's keep all the questions toward the end. Of course, when it will be her turn, we'll start with a question for her first, and then we can continue with the questions for the other sessions. So I did mention that KFF is not present with us, so they have allowed me to make the presentation for them. Okay, thank you very much. So basically this is coming from the Kaiser Family Foundation, who's been providing data on disbursement really on family planning from donors. So, you know, this is done by our colleague Adam Wexler, with whom we work with, and provides us with the information. Next slide, please. There we go. So, a small introduction methodology. As I mentioned, you know, this is something that Adam does very well. So I'm trying to put my shoes on Adam's side. I'm much bigger than he is, but I think he's smaller and certainly a little more agile in his presentation than I'll ever be. So bear with me. So basically, the way this activity started is that KFS started collecting data on donor government funding for family planning following the first family planning summit in 2012. And they basically, similarly to what we did with FPSA, adapted the methodology to monitor donor government spending on HIV in collaboration with USAID. They just transform it for family planning. So it's basically the same methodology, just like transferred to family planning. And the current report presents data estimates for 2021, which is the most recent year available. But they do have, you know, a database of data from 2012 to 2021, which will be presented also. So the methodology includes funding data from all members of the Organization of Economic Development and the Development Assistance Committee. I'm not sure of the acronym, how it was selected, and I found it very weird as to what it does. But it's a database of data of expenditures, but from the advanced industrial countries. So it's direct data collection that they do from 10 donors, and the list is here. And there are also some other donor members from the CRS database, which is another database. So he works with both of them. So basically, KFF uses data on bilateral funding, which includes any earmark for family planning designated amount, FP specific contribution, family planning specific contribution to multilateral organizations such as UNFPA supplies, and funding provided under other assistance activities whenever it's possible. And the data is validated. So KFF does some prior work and then goes back to those 10 donors and just basically dwindle down with them and get like a more precise figure with them, and they validate it before it's considered to be publishable and official. Next slide. Oh, I can do it. Bilateral funding. So basically the results are for 2021 is that donor government funding was essentially the same between 2021 and 2020. As you can see, it's a small decrease. It's 1.4 for both years, but you know, with a small decimal here. Some variation among donors between 2020 and 2021. 5 have increased: Australia, the list is here, Denmark, Germany, Norway, Sweden, and then some more than double their funding in 2021. And 2 of them have declined, which is the Netherlands and the UK. The decline by the UK, which was not unexpected. I think it's part of the Brexit issues about, you know, reducing ODA funding. And that was completely offset by increase by other donors. And basically mentioned earlier, kind of like the US and Canada basically stayed flat. So this is kind of like the picture of the government bilateral funding for family planning since 2012. So you have the data here. You can see that, you know, after the first summit in 2012, there was kind of like some major increase. But if we can look at it, it kind of like stays the same. It has not really increased significantly, but, you know, some decreases in the last 2 years. And again, some sort of changes here in terms of the donor government bilateral funding in family planning, showing kind of like the between 2020 and 2021. You look at Sweden, Germany, and Australia, which have increasing significantly. Then you have Canada, Denmark, and Norway, which have increased around 5 million each. And then the Netherlands, US, and UK, which have some big decreases. And the UK, again, has to do with the whole Brexit and reducing their ODA funding. And this is kind of like the pie chart as kind of like who are the big donors and who are the smaller donors as expected. The US is still the largest contributor, 42% of the funding, followed by the Netherlands, and then everybody else kind of like goes a little bit down for during 2021. So basically, donor government funding has generally increased in 2012, but not by a whole lot. But there has been fluctuation over the period, so it has not been kind of like at the same amount. There's been like some ups and downs. In 2021, donor government funding was approximately 200 million above the 2012 level, okay, but below the peak level, which in 2019 it was 1.5 billion. Funding from 7 of the donors profile here were higher in 2021 than in 2012. And while the UK and the US have historically been the largest donor, the overall trend has been driven by really other donor governments. So again, showing you kind of like the two biggest donors, which are the UK and the US, and all the other donors. It shows you kind of like how the blue line at the bottom is the UK with the significant decrease. The US kind of like staying kind of like, more or less at the same level, around 1.2, 1.4, 1.2 to 1.4, and then the rest as really kind of like is the one that's really kind of like driving up a little bit kind of like the overall increase. Okay? The key issues is that donors continued and increasing reluctant to disaggregate family planning funding from broader development assistance. And also the one area that KFF or ADAM has not been able to really seize is the humanitarian and refugee assistance in family planning, because it's a whole package, and trying to pull what's really specific to family planning is very difficult, but it's something that they're still working on. The next step is the KFF report, Donor Government Funding for Family Planning in 2020, was released on November 14, so just recently. And data collection for 2022 family planning funding will begin at the end of the year in early 2023. The one other area that I think that we've been discussing with KFF also is trying to understand how you can allocate some of those funding to specific countries, because this is just money going out, but where it's spent is still kind of like an issue. But they're working in that. I cannot promise anything, but something that we are kind of discussing. That's it. Thank you very much. And yeah, so if any questions toward the end, we can do it. And now Angela Maika from the University of Washington, she can also make it, and she made a recording of her presentation, and I hope it will work. Otherwise, I'm going to be forced to talk for her also, which I don't want to do because she knows her stuff much better than I do. I'm sorry? No, let's wait till the end. Yes, because we want Michelle to go before, because she has another. We're not hearing.
In the Department of Health Metrics Science at University of Washington. I'm delighted to share the results from ongoing work tracking development assistance for health in general, and in particular for this conference, results for family planning in particular. In terms of outline, I'm going to start with a brief background and share details on how we generate the estimates, as well as the results, the latest results we have, both for overall development assistance for health as well as family planning in particular. So in terms of what actually distinguishes the estimates that we generate at IHME for development assistance for health. There are some specific ways in which that the estimates we generate are distinct. So first, we include a broad set of channels. This means that in addition to the credit reporting system from the OECD Development Assistance Committee that is typically used to generate estimates of development assistance for health, we also include additional data that captures private foundation support as well as NGO disbursements. We also distinguish between sources, originating sources of funds and the disbursing entities. So here, originating sources of funds could include national treasuries, whereas the disbursing entities will focus on the major international development agencies. Thirdly, we put some effort into accounting for double counting in the estimates, which may happen when agencies transfer resources between themselves. And so we leverage revenue and income statements to do this. And then we also split each dollar amongst the various health focus areas and program areas that we track, and generate a preliminary estimates for the most recent full year for which we generate estimates. So this would mean that for 2022, last year of data in our latest database will be 2021, the most recent year that has ended. And then we track this, the estimates from a donor perspective, and so we report in US dollars. Moving on to methods, this is the overall framework that we use to frame the work, looking at resource flow from the perspective of the donors. And so we start from originating sources that could be the national treasuries, international finance, institution debt repayments, private philanthropists, and corporate donations. These are what are considered as the originating sources of funds. And these are passed through international development agencies, which are inclusive of the bilateral agencies, UN agencies, the multilateral development banks, the Global Fund, Gavi foundations, as well as NGOs. And then these resources dispersed through the international development agencies finally delivered to recipient implementing institutions in low and middle income countries. So these could be directly to government programs at the National Ministries of Health or disease control programs, or through to non-governmental agencies that include national government and national non-government organizations or private sector contractors, as well as universities and research institutions. So this framework is the overall structure that guides the work. In terms of data, we, as I mentioned earlier, incorporate a much broader list of data sources, inclusive of the predator reporting systems and databases of the OECD Development Assistance Committee, as well as additional data on foundation contributions through correspondence and online project databases from the major development agencies. How are these estimates created? We have 3 steps here. We begin at what will be the International Development Agency channel level, where we create estimates leveraging a keyword search function to help us distinguish what the various projects, what health focus areas or program areas the various project activities were related to, based on the project descriptions that are provided in the various databases that we leverage. At this stage, we also generate in-kind contributions, which are also known as administrative expenses for the agencies that are transferring these resources. We also generate the preliminary estimates for the most recent full year. And so at the end, we have a data set that is disaggregated by source, channel, recipient, country, health focus areas, and program areas. And then we bring all of these to the second step, where it involves a leveraging of financial statements as well as income and revenue statements to make sure that double counting or the transfer of resources across disbursing agencies are accounted for all in once, so that, let's say, the Global Fund gives some money, not the Global Fund, the US gave some money to the Global Fund that the Global Fund also gave to UNFPA for a project. We want to ideally track the resource flow mainly from the US to, as if it happened from the US to UNFPA, because it's the same resources that was just moved twice through Global Fund and to UNFPA. And so once we're able to complete this step, we have a data source that's mapped more uniquely from source, channel, recipient, country, health focus areas, and program areas. And then in the final step, we do a lot of internal review to assess the data and the estimates that have been generated, as well as sharing it with contacts at the various international agencies to make sure that the estimates we have are generally in line with what they are tracking internally as having shared or distributed. I mentioned that we use a keyword function. This slide lists the actual keywords that we use to flag first the general the projects that are related to the general area of reproductive and maternal health, under which we track family planning, and then the specific words that we use to track family planning per se. Moving on to results here, my first slide looks at how much has been spent in aggregate for development assistance for health overall. And so the figure to your left is the total annual contributions towards development assistance for health. We see that over time, beginning in 1990, where we start, generally development assistance for health has increased, even more so in the last 2 years, thanks or in no part to the health-related response to the pandemic. And so we're looking at, in 2021, 67.4 billion having been contributed as development assistance for health. And to your left, the figure looks at this level aggregate funding in terms of percent across time. And so across the various health focus areas, how have their shares evolved over time? And so we see that whereas different health focus areas have gained priority across time, in the most recent 2 years, thanks to the pandemic, the other infectious diseases have taken up a significant share of resources targeted towards development assistance for health. The next slide looks more specifically at reproductive, maternal, newborn, and child health funding, looking at how much has been spent over the period from 1990 to 2021. And it's inclusive of funding targeted towards family planning. And so the stack bar here is showing that in aggregate, a total of 14.8 billion has been contributed towards reproductive and maternal, newborn, and child health. with the blue bars at the very bottom highlighting how much has been put towards family planning per se. The next slide here, also a stack bar, looks more specifically at family planning and how much has been spent over time across all the various disbursing entities that we track in the study. And we are estimating a total of 1.2 billion having been spent on family planning across all the various disbursing agencies. The next couple of slides will look specifically at various disbursing agencies. And so here we focus on contributions from bilateral agencies. Again, a stack bar highlighting the evolution of resources that have been disbursed through bilateral agencies across time. In aggregate, in 2021, we are looking at about 760 million having been transferred. The majority of which was transferred through the U.S. bilateral agencies. In terms of foundation, we are looking at an aggregate of about 356 million having been transferred in 2021. Over time, we see that different foundations have played a role here with more of a role or dominance for other private foundations at the very beginning of the time series that we have, and increase a role for the Bill and Melinda Gates Foundation here in more recent years. Lastly, we have a slide that's looking at other sources. And these might include other sources such as investment income at the development banks or repayment sources. We see here that not a ton of resources have come from this particular source and has varied over time. And in 2021, we're seeing that of the 50 million that originated from the source, the bulk of that either came from investment or other foundation sources, other unidentified sources. So in terms of, we have slides that look at in aggregate spending per woman of reproductive age, how much resources have targeted women of reproductive age across income groups over time. And so this figure compares that contribution levels in 2020 with that of the contribution levels in 2000. And we see that over time, it seems that a little less is being contributed in the more recent years. However, across income groups, it seems like the majority of funding has been targeted towards low and lower middle income countries, which is what we will generally assume was happening. In terms of regional, across regions, again, here we note that in the earlier years, in 2000, relatively more seem to have contributed per woman of reproductive age compared to 2020, sorry. And here we note that on average, per woman of reproductive age, more resources have been targeted towards women in sub-Saharan Africa, with about 1.20 US dollars, 1.2, sorry, US dollars being contributed to women on average in sub-Saharan Africa. What are our key takeaways here? In 2020, donor support for family planning was about 1.2 billion in 2021 US dollars. The main provider of this fund was the US, and has been since 1990, with the exception of 2021. Majority of this funding has been disbursed through NGOs, the U.S. Bilateral Agency, and the Bill and Melinda Gates Foundation. And in 2020, the top recipients for this funding was Kenya and Nigeria. And on average, across low and middle income countries, about $0.5 have been contributed in development assistance support for per woman of reproductive age. Thank you to the broader DAH research team at IHME who together produce these estimates and a lot of the analysis related to this, as well as to ongoing financial support from the Bill and Melinda Gates Foundation. Thanks.
She's not here to receive our thanks, but I'll communicate to her that you clap for her presentation. And now my colleague Michelle will present her. Michelle, I'll let you talk about what you're going to be presenting.
Great. So we're kind of completing the picture of expenditures. We started hearing about the role of government expenditures, have just heard two different perspectives around donors. And so I'm going to talk about that last sort of part of the pie of out-of-pocket expenditures on family planning. And this comes from work that we've done in collaboration with the Reproductive Health Supplies Coalition. So before I jump into results, I just wanted to kind of start us off with a couple of background questions to ground us. So first, in this context, when we say out-of-pocket expenditures, what are we talking about? And what we're really talking about is the estimated value of what individuals are paying when they receive contraceptives from private sector sources. So this includes private clinics, pharmacies, and shops. I will make a note that we know that in some instances there are public sector user fees, whether official or unofficial, and this work is not capturing that public sector out-of-pocket contribution, but really just looking at what is spent within the private sector. And we've had lots of discussions about if and how we would be able to value that public sector expenditure piece, and I think it's something interesting to look at, but we are not yet there in being able to capture that well. So second, why do we care about out-of-pocket expenditures? So I'd say first, is recognizing the contribution that it's making, right? So until we quantify something, it's hard to really kind of give it visibility. And I would argue also that it really helps us identify potential needs to alleviate financial burdens in accessing contraception. And so that we might see places where we think that what is coming from out-of-pocket expenditures, could benefit from additional subsidies, additional support, or might be producing kind of financial burdens that are making contraception less accessible, less affordable. And how we measure this, so the commodity gap analysis, which is a long-standing report that Avenir has been doing with the RHSC, kind of took a first step a couple of years ago at measuring this out-of-pocket expenditure component. And last year, we transitioned from the commodity gap analysis to what we're now calling the LEAP report. So the LEAP report produced estimates for 129 low and middle income countries. The report itself is sort of globally focused, segmenting results by income group, so low, lower middle, and upper middle, but we also make country-level results available through an online custom reports tool. Very excitingly, as we made this transition from the commodity gap analysis to LEAP, we also expanded into some new health areas. So the report now covers the supply costs associated with menstrual hygiene, abortion and post-abortion care, and some essential commodities for maternal health. So for the purposes of today, we're just going to talk about the contraceptive piece. So in LEAP, we look at current users of contraception by method and sector. We estimate the volume of commodities that those users will need, and then we apply price points to estimate the cost of those supplies. The report also includes projections into the future at 2025 and 2030 endpoints, though for the purposes of what we look at today, we're going to look at the sort of current spending estimate. Though the report came out in 2021, because there was so much uncertainty around what was happening with COVID and our data sources hadn't really caught up with that, we made the choice to baseline our current picture in the LEAP report as 2019. So the data we're going to be looking at is from this kind of newer report, but with that little bit of time lag of looking at 2019. So as we look into private sector expenditures, one of the things that we really kind of started to explore a few years ago with the commodity gap analysis is this complexity of what happens in the private sector, and recognizing that not all women who go to private sector outlets are necessarily paying commercial retail prices, right? You have women who are getting free services with those funded through various mechanisms, or women who are buying products, but those products are subsidized, so they're buying them at kind of below market prices. And we know that a lot of that comes from NGOs or SMOs, but there's also complexity there, because not everything that these types of organizations are doing either ends up in the private sector. For example, you might have mobile outreach services that happen in public sector clinics, but also not everything that these organizations are doing benefits from a subsidy. So more and more we're seeing in countries, some of these SMOs pivoting to having sort of non-donor supported channels that are really kind of self-sufficient. And so we wanted to also move away from just saying, okay, this is what an SMO or an NGO does, and this is what something else does, but really try to identify where is it that a subsidy kind of got into the private sector, whether that comes from donors, but also recognizing that there are contexts where governments are also putting that subsidy in. So whether that comes from contracting out of services within the private sector, or for example, in India, the government has historically purchased contraceptive pills that are then distributed out through private sector kind of SMO type organizations. And so I think we often think about that subsidy as just donors, but there are other examples of that subsidy kind of moving across. And so what we're really trying to do in LEAP is isolate among those women who go to the private sector, who are paying that kind of commercial price point and valuing it at that, and who are getting that product free or subsidized and being able to value it at that lower price point, and accounting for both of those pieces. Just in the sake of time, I'm going to go a little bit quick through this slide, but essentially we start with users by method. Our user numbers are aligned with UN Population Division projections and estimates. And within LEAP, we make estimates of shifts in method mix, taking country data as a starting point and looking at recent patterns of change at a regional and sub-regional level to inform what those changes might look like. We use source data, primarily from DHS and other surveys, to make that split between public and private. And then we use an analysis developed by LEAP, leveraging data from social marketing organizations, from NGOs, from the DKT social marketing statistics, as well as from some government data to try to make that distinction of that public versus private sector. This is all done by method and country, so accounting for the fact that these markets often look different across methods within a country, but also across countries as well. So we get our quantities, and then we apply these to price points. So for our private sector work, our price points come from a range of different data sources. I will say we have a little bit of sort of apples and oranges issues in being able to pull all this data together, but wanted to cast as wide a net as possible in being able to get that full picture of what expenditure looks like. So we use household surveys where women are asked about how much they paid for their contraception the last time they got it. We have data that we purchased from IQVIA, which is a company that tracks sort of retail prices. So this tells us from their work kind of what consumers are being charged at retail outlets, and then a number of other surveys that contribute kind of similar types of information. And we use all this to come up with these two price points for each country, that non-subsidized price point, so kind of representing that commercial price, so those who are not benefiting from that subsidy, and then a subsidized price point, which accounts for that share that are free, and then that share that are receiving commodities at that lower subsidized price. Overall, around 80% of our out-of-pocket expenditure estimates are derived from where we have a country-specific unit price. And so while we do sometimes rely on regional averages, we feel fairly confident in our results, and that we have been really able to have country-specific data for a lot of the coverage, at least in absolute terms. We published a paper last year looking at the private out-of-pocket expenditures. This paper used data from the 2019 commodity gap analysis. For this year's LEAP report, we used the same unit prices that are published in this paper, and there's annexes with all that detailed data available if you're interested. But we applied those unit prices to our updated estimates of users by sector. And so you'll see the numbers in that paper are a little different than what I will talk about today. So this is a graph from that paper looking at the variation in price across 4 methods. So implants and IUDs on top and injectables and pills on the bottom. The green represents the non-subsidized prices and the orange represents the subsidized prices. I won't go into a whole lot of details here, but just note that we saw both a wide range within regions. So you can see sometimes those bars are quite wide. So we have a lot of price variation happening and a lot of price variation happening across regions, and some differences for different methods of which regions seem to have the highest prices. So a lot of kind of complex things happening in terms of this market, which we recognize are influenced by a whole range of different factors that are kind of at play in these different markets. So when we put all this together, we get to our estimates of total spending on contraceptive supplies by sector. So here we have some public sector spending estimates. This differs from what my colleagues earlier today looked at because this is just looking at that commodity piece. So we know it's an important piece, but by far not the whole picture of expenditure on family planning. But then adding in that private sector piece, we see it is quite substantial. So we estimate about $3.2 billion in expenditure across low and middle income countries, though as you can see, the large majority of that, about $2.7 billion, is coming from upper middle income countries. Also from that graph, you can see that that is largely driven by pills. So I'd say that kind of pills purchased by women living in upper middle income countries accounts for the vast majority of this expenditure. Separate from what is in LEAP for FP 2030, we've also made some additional estimates of the cost of sterilization. So since LEAP is really just interested in supplies and commodities, we just value private sector sterilization at a sort of standard supply cost, but wanted to be able to recognize that there is more expenditure there. And so have done some separate estimates and estimate there's about 130 million more that we're missing in our out-of-pocket expenditure estimates if we take that into account. So given how much pills play a role, I wanted to just spend a minute looking at pill prices. So the graph here shows the average unit price of non-subsidized private pills across countries. So this is for each country. If we had multiple data sources, this is the median price in that country. And you can see there is just quite a huge range. So at the top end, we're nearing $20, and at the bottom end, less than 20 cents. Again, we know there's huge diversity in pill markets. There's different types of pills. There's places where you have local manufacturing and more generics available and places where you don't. So a lot of complexities that go into this wide variation, but also just to note that, this leads to some real discrepancies and differences in terms of what does it look like to be able to afford contraceptive pills through private sector outlets. In the summary table at the top there, so this is taking that kind of unit cost per cycle and multiplying it out by the average number of cycles that women need over the course of the year to think about, well, what does that look like in terms of a cost per user per year? And we see getting quite high in upper middle income countries at $65. Interestingly, the way kind of our data has played out, we end up with a little bit of a higher, or maybe a much higher, double cost in low-income countries among pill users than in lower middle-income countries. This is due to both sort of the unit prices that we see of those pills, and again, maybe thinking about the role of large manufacturers in Asia might need some cheaper access in the private sectors in those countries, as well as then the blend between that subsidized and non-subsidized price point, which we see is also quite different, right? So around $2 for a subsidized pill user compared to nearly $30 for a non-subsidized pill user. And so that overall is sort of a dynamic of what all is happening around that. So before I finish, I wanted us to just zoom out a bit and kind of put this into context, pulling in then that public sector estimate. So again, this is just looking at supply costs, not the full picture of public sector expenditures. But what we see in LEAP is this really kind of shifting role of the role of out-of-pocket. So we see it playing a fairly pronounced role across all income groups, but proportionately increasing across them. It is easy to think about this as a transition, but I want to challenge us to not think about this as sort of an inevitable pathway, that low-income countries, as they transition away from donor funding, as things evolve, that the only way that we can transition forward is to have this sort of shifting role to private out-of-pocket, right? And I like to kind of think about the US versus the UK as our endpoints, right? We have very different situations in terms of how healthcare is financed and what that means in terms of what individuals are paying and how that is done. And so while it's easy to look at this graph and kind of think, oh, this is where we're going, I think there's a lot of cautionary tales and what it means to move towards a really out-of-pocket driven family planning market, right? And a lot of issues around access and equity and accessibility of services. And also, if we contrast ourselves, right, I think we often get siloed in our family planning thinking, but if we look at a broader picture, so this is drawing on some work by colleagues at the Center for Global Development that looked at health expenditures across all healthcare products, right? So family planning is a pretty little sliver, right, when you zoom out and take into account all the different things that are bought in health markets. And here we see this very different pattern, which is this sort of U shape or boomerang shape, where initially there's a lot of donor funding, right? That as that donor funding transitions out, there's often this sort of temporarily shift towards more out-of-pocket, which is probably a result of some not great transitions out, right? And then the government sort of stepping back in to fill that public sector role. And so, you know, I would challenge us to think about, are there ways we could do this transition even better, right? As we've heard a lot this week about, you know, donor money being limited and what does that look like? And there are ways to maybe do this transition where we don't get that dip at the bottom that's sort of putting burden to women and then pulling it back to governments. But there are ways that these transitions could be done where governments are stepping up earlier, where that donor to government transition is done in such a way that we kind of maintain public share along that transition. So just to wrap up, you know, we see a large role of out-of-pocket expenditure across all three income groups. I will note, though, that these totals of income groups hide a huge amount of diversity at a country level, and we don't have time to look into the country data today, but would encourage you to look at the custom reports where you can see these graphs, you know, presented by country for all low-income countries and lower middle-income countries and upper middle-income countries to see that diversity, right? So you have some low-income countries that have lots of out-of-pocket, and you have some lower middle-income countries that have very little, right? So these aggregates are a nice narrative, but hide a lot of that diversity. And then again, just this word of caution. I think that there is a lot of, we don't want to be beholden to sort of a path dependency of because this is how kind of financing transition in the past, right? And that upper middle income country is largely Latin American countries. A lot of that comes from Brazil, right? Where we know that there are huge burdens of unintended pregnancy, a lot of issues with access to a full range of methods, right, of a high dominance of pill use, and that we want to think about how do we look at this information and use it to help us plan for what is perhaps a different trajectory as countries progress across these three income levels. So I will end there and then hand over to Rudolph to wrap us up and hopefully have time for some questions.
Thank you, Michelle. So I like to call the out-of-pocket kind of like the cream on the top, because, you know, we generally speak about what are donors spending, what is government spending, but that's the first time we've been looking, well, not the first time, but, you know, it's a new area of interest. Is kind of like what are consumers spending in family planning. So what do we do with all this data that's, I didn't realize I had this, that, oh yes. Oh, yes, that's right. It's not a separate presentation. Yeah, so how do we wrap it together, okay? I think that, you know, going back a little bit of kind of what do we mean by government expenditure, I think that Julius already went into presenting what it is. Next slide, please. Oh, you can do it. Hold on. Yes, so basically why we kind of like started, a little bit of context is that Track 20 project follows the domestic expenditures on family planning. Julius mentioned that, you know, it's both at the central and decentralized levels. So it's not just the central government that we're looking at. We're not looking at donor budget or support or transfers, and it includes loans when we can catch them. And it's also similar to the other 17 Track 20 indicators that our monitoring and evaluation officers, some of them are in the room, are following. Okay? And what does it mean? It's really recurrent expenditures. I think that when we started this kind of work on expenditures, the first interest was how much government are spending in commodities, contraceptive. No, we go beyond that, so it's everything else in recurrent expenditures. The health personnel that Julius showed you talked about the way we dwindle down or arrive at some specific FP expenditures for human resources, for management, the program costs, IENC training and others, and what's been effectively spent. So overall, FP expenditures by themselves do not exist. So, you have to come to this dwindle down or just kind of like trying to make it estimate what's really specific to do it. We've come with a methodology that's there. Actually, that's probably the next ICFP, a poster presentation or some about how to do this, and probably using some live data to come up with that. And generally, the data is not available very easily. Like, for example, we're in 2022, we have some time to wait for a year or two to get the data, and I'm going to show you. So it's generally 1 or 2 years delay in obtaining the audited health expenditures from which we derive the family planning specific expenditures. How are government expenditures approved in country? It's a two-step process. First, the institutions, the consultants who do the work, they have the tool that Track 20 developed and the different guidelines. They work with the family planning program, the finance and administration department of the Ministry of Health, sometimes the Ministry of Finances, and certainly with the health account teams. For example, in Cote d'Ivoire, we work with the health account team. If anything, they help us correct something, and they came up with some very good solution as to how we could do some estimates. And during this first step is basically what is the data source, what is the data limitation that there is, and then can we get some missing information, or can we get some better information? And then there's another process, which is now with the family planning stakeholders. Track 20 has what they call the consensus meeting, where the other 17 indicators are presented. And during that time, the government expenditure data is presented to the FP stakeholders. And sometimes we have consensus meeting just on the validation meeting just for the FP expenditures. Then the data is submitted to Track 20 by Track 20's monitoring evaluation officers to Track 20 in the US as part of the overall consensus meeting report. How do we work with all of that? So, we're talking about different institutions provide data. So here is a list here of many of the institutions, which is FP 2030, USAID, UNFPA, obviously, the Kaiser Family Foundation, who provide us with the donor disbursement estimates, WHO, the health accounts team that we use, and I'll show you a slide in the next one as to how we use them. Good Matter Institute, the Global Financing Facility, the Gates Foundation, the Reproductive Health Supply Coalition that Michelle mentioned, and then IHME and others. And we used to meet twice a year. With COVID, that's kind of like been reduced, but I think we need to restart that a little more frequently, if not even quarterly, having something, let's talk about it. Where, basically during those meetings at the interagency meeting, is basically it's really the donors and the out pocket is really discussed more really on the development partners, but the government expenditures that Track 20 collects is presented, but generally I must say there's not a lot of question because there's a lot of details that they don't have, but it's so, and then Track 20 prepares and updates report for FP 2030. And I'm giving you an example of in the FP 2030 report, this is what we submitted 3 weeks ago to you. And kind of like showing all the different countries and the source of data. And this is where I'm going back to WHO here. Yes. So sources of the data or the estimates. So we used to work with the Netherlands, UNFPA Finance, Netherlands Interdisciplinary Demographic Institute, which used to do this kind of work also. So for Afghanistan, the latest year that we have, I mentioned the T-1, T-2, now it's almost like T-3, is the latest year we have is really 2019, and the source of data was UNFPA. For Bangladesh, The latest year that we have is 2020, but it's the family planning spending assessment, what Julius showed for Kenya. It's the same methodology. And for Bhutan, what we're still using is the health account data that WHO provides. So you see that we don't have the data for all the countries. We cannot conduct in all the countries. This is just a partial table I counted this morning. It's 40 countries that we have in the table, and you will have access to it soon. I did not want to preempt my friends here. I think Julius showed you already this. This is a slide of kind of like where you can get the country-specific data in all the tables here. Hold on. Yes. So, you have the data from all the different years that are here. So, you go into the Track 20 website, you navigate until you get that. And once you go into there, you can see all the details, the same details that Julius presented. You can see it in the Track 20 website. And then adding all together, we're talking about the government expenditures, the donors' expenditures, and the out-of-pocket. So I've used last year's report. I did not want to preempt December 1st of this year. And our friends here? That's what Yassine told me, but I missed that. But, so I used this last year's report just to show you a little bit of what we have in terms of total expenditures on family planning. The total is 4.3 billion. And obviously, the international donors is 45%, sorry. Domestic government is 41%. I think we've seen an increase. I think, Jason, we need to do an analysis of those different years. And then out-of-pocket is 14%. So I just learned that the FP 2030 released a report. I remember that the data has not changed, really. I think it went down 4.0, or it's about the same, right? 4.2, so about the same. So in the FP 2030 report, you have the latest data and all those different figures that I just showed to you. So this concludes the actual presentations. So I'm sure that there are lots of questions. What I'm going to ask is that if you have questions, let's start with the out-of-pocket questions, because my colleague has another presentation that she needs to manage in a few minutes. So opening up the floor to you. Osama.
Yes. My name is Osama Refat. I am international consultant for population development and representative for population communication and policy communication in California. I have one comment for
Osama.
Kenya.
Osama, hold on. Okay.
Yes. I have one comment and two questions for our colleague from Kenya. My comment, the people or the women who are coming here to have services for family planning, we are calling them clients and not patients, okay? While you are talking, you are mentioning that all the patients coming to the outpatient clinic and family planning, they are not patients because they are healthy people, okay? So this is number one. At your presentation, you have mentioned I think that the second slide or the third slide, the contraceptive methods, okay, frequently. But you have put the insulin. What is the role of insulin in between the contraceptive methods? Do you pay or your government spent for insulin regarding the family planning? What is the role? My second question, you have a triad in between the provider and service provider and consumption, and then the financial resource, okay? So you are starting from financial resource and going by the arrow to the service provider. Do you mean here you are paying a fees for service provider to serve, or the frequency of the route of pathway of your financial resource, which is starting from financial resource till service provider, then it goes to the family planning service and then consumption. At this consumption, you are selling the contraceptives. That's why you are collecting the money again. This is what you mean? I would like to clarify these points. Thank you.
Thank you. Do
Finally,
you want to answer? Or
finally, a
do you
little
want
bit,
to round robin?
a little bit comment about our colleague.
Yes, please.
The out-of-pocket now, I'm going to speak about Egypt. It's a very, very critical and difficult. Last 10 days, the dollar has an increased inflation within 1 week. Every day, every day. So that will be reflects on the market, selling, and service provider also. So we can't identify exactly and calculate it exactly. Thank you.
Thank you, Osama. So again, I'm going to ask people if we could do out-of-pocket question first, so that Michelle can liberate herself and move on, and then we can go back to the donors and to the government. Thank you. So if you pass here.
Thank you. This is more of a comment than a question, I guess, but related to out-of-pocket expenses, I understand you're looking just at the fees or the cost of the commodities they're paying, but frequently there are other components of out-of-pocket expenses. And I've always noticed that when we look at this, it's sort of, we are underestimating actually what it is costing the client, the individual, to provide, whether it's from the government or other sources. There are out-of-pocket expenses related to transportation, et cetera. And I don't have an answer, but maybe perhaps you have been thinking about this. Is there a way for us to better capture what it actually is costing to provide family planning services to the individual as versus cost to the private sector or the government?
Hello, this is Lucian from the International Rescue Committee. So Michelle, I like your nuanced interpretation on the costs from lower income countries to middle income countries to high income countries, and that transition, and your cautionary tale that it doesn't have to be this way. So is the solution the other graph that you showed where it transitions from donor subsidy towards government subsidy? Or do you have any other ideas of alternative solutions that the trajectory of the cost could go to? Thanks.
Hi, everyone. I'm Kaya from Propel Health. 2 quick questions. First, Michelle, really, really interesting. Thank you for that. I was wondering if you could maybe hypothesize a little bit on what the subsidized and non-subsidized out-of-pocket picture may be during COVID times and today, if you've given that any thought on what you think, how it may compare to the 2019 picture. And then for Julius and also for Rudolph, I'm really interested by the FPSA. But my question to you is, how far are we from a really durable government-led or owned expenditure tracking solution? And is the vision to kind of transition FPSA or some sort of equivalent fully to government in the future? If you could just reflect a little bit on that, because clearly that government-owned piece is probably where we all would ideally like to be. That's all for me.
Other out-of-pocket, we will come back to you, Kaya. Let's let Michelle answer first.
Thank you, Michelle. I had a question about the increased pill price in lower middle income versus low. Could you please clarify on that?
Okay. So why don't you go ahead, Michelle, because I know that you must be, is somebody else? Yeah.
I might, I have to moderate a session way on the other side of this complex in 15 minutes. So I will answer a few questions and then have to run, but I'm happy if people have more questions to follow up on email or try to find each other later. Very quick? All right, we have a quick burning question.
Thank you, Michelle. My name is Margaret Edison. I'm a Nigerian, and I work with the National Population Commission. I'm looking at your estimation of the out-of-pocket expense, but you focus on the private sector. But I know that a lot of women do spend for the government clinics out of pocket, because when they get to those clinics, they're asked to pay for consumables. And I don't know, because it's good for you to also have an estimation of how much of the out-of-pocket expenses is spent by women in the public facilities as well. Can I
So
ask,
Mich-
ask other questions?
For the
Great.
other parts. Okay, Michelle, go ahead.
Thanks.
So that you can-
Yeah, so maybe I'll take in reverse order with that. So yes, we recognize that there is public sector expenditure, right? I think sometimes it's more official in the terms of official user fees, and sometimes it's more unofficial, right? Where technically services are free, but we know women are being asked to pay. I would say especially in that case, right, there's thorniness of being able to, even have data and visibility into what that looks like and think about how to put those estimates together. So I think it's something we have talked about and are struggling with, and maybe together it's something, we look at trying to get a better handle on, because I agree there's a lot of visibility that is not there to additional expenditure that is happening, and then kind of creates an unfair comparison, because it's not that public sector is necessarily free. In terms of the pill prices, I mean, my hypothesis would be that it's because you have a lot of pill manufacturing happening in Asia, and so there's very, very low prices happening, and that what makes it into the African markets is costing more. That would be my hypothesis. I haven't kind of sounded that out fully, but yeah. And what we did see actually in the IQVIA data is that oftentimes in Asia, even the commercially priced pills were at the same or even lower than sometimes like the donor prices. So, quite low prices happening there. In terms of COVID, so we actually just are finishing an analysis we did with IQVIA to look at their data to try to understand if we see COVID impact, and then if that impact was differential between subsidized and non-subsidized products. And I will say, so it was across 3 countries that we see very, very little, and that we didn't really see a difference. So we kind of tested out that hypothesis of were subsidized products more resilient? Did those sales kind of not have changes as others did? And for the most part, we saw that sales were pretty steady. So that work is coming out very soon under MPHD. On the question of transitions, I think this is what we all struggle with, right? Is where does that money come from, right? I think there are different models of health insurance that could be government financed, but could be financed in other ways. And I think there are kind of creative ways to explore what that looks like. That doesn't necessarily just mean kind of individuals paying out of pocket, but having family planning incorporated into health insurance schemes, and whether those insurance schemes are fully government funded or they're funded through other means, through some out of pocket, right, but sort of paying a premium and then having a package of benefits versus paying for each service along the way, or through employers or other things like that. But I think it's what we are all grappling with, especially in this current climate of constriction of both donor money and government money, right? We have to recognize that governments are really struggling, and COVID has exacerbated a lot of economic issues that, having that money to step up is probably not realistic. Okay, so with that, I think you're also over time for your session, but
No, I think I'll answer to John's question. Yeah. Yeah.
Sometimes out of pocket, you are calculating in any government, okay? Government spending $1. How much you could save for the expenses on this government? This is the issue of the outcome of spending $1 in family plan.
Definitely.
So it looks like we are out of time. We should get out of the room. The session ended about a minute ago. So we can always communicate. Let me just add one more thing for John. Yes, you talked about, we talked here about the financial costs. We could do a lot more, maybe on economic costs, women going, traveling, family planning. There are so many other ways that we could address it. You and health resource tracking, the only program for which I know there is some sort of resource tracking that's accepted is in the HIV field between the Global Fund and PEPFAR. Gavi immunization, maybe, I'm not sure, but the Global Financing Facility is started to think about how to harmonize all those resource tracking related to family planning. That's going to take a while. So that's all I want to say for now.
Thank you. Okay.